Good evening, dears. The topic I'm going to present today is principles of hand splintage and physiotherapy. Hand is the most important functional unit of the body, and the impact of finger and hand deformity or loss not only impairs a patient's daily living and work activities, but also affects the patient's self-image and willingness to socialize. As hand surgeons, we deal with a lot of fractures, tendon and ligament injuries, soft tissue injuries, inflammation and infection of the hand, and hand burns. Our ultimate aim is always full functional recovery to provide the patient with a sensate, pain-free, stable, and supple hand, which enables them to return to daily activities and work. Three prerequisites for prehensile hand functions are mobility, stability, and strength. And is the surgery final? Never. The splintage and physiotherapy is very essential. Any hand injury management is incomplete without appropriate rehabilitation in the postoperative period. The treating surgeon should have a sound understanding of the rehabilitation of the injured hand. For that, he should be having thorough and sound knowledge of anatomy as well as biomechanics of the hand. Splintage and physiotherapy depends on what structures to be repaired. The contractile structure like muscle and muscle tendon unit, or non-contractile tissues like bone, nerve, or other soft tissues. And pain management is considered to be very important. Hand injuries are mostly painful and require careful attention to pain control as pain limits movements and strength. Early mobilization is encouraged in the majority of therapy programs, and good analgesia is the key for successful patient motivation. What is the purpose of the splint? First and most important purpose is pain relief. Then it comes the immobilization and prevention and correction of deformity, edema control, maintenance and restoration of a range of movements, scar remodeling, and support and position of during the function. And I would like to say a few words about the impact of edema. Edema on the dorsum of the hand causes the skin to tighten, forcing the metacarpophalangeal joints to hyperextend. Fluid accumulates within the tissue layers, sheath, periarticular capsular structures, and within the synovial space. Edema acutely impairs the function of the joint. With prolonged edema, the articular capsular structure and collateral ligament fibrose, effectively shortening them. Both types of edema, fluid, both transverse as well as exudate, can cause problems in the hand that can lead to joint stiffness. Exudate lead to fibrosis and joint contraction. Management of edema start in the acute setting by elevation of the hand, followed by subsequent compression bandage and garments, massaging, and active movement therapies. Splintage is also depends on the part we are treating, whether it is a post-tendon repair, tendon transfer, fracture, nerve injury, or a soft tissue injury or burns. Why we should be giving a splintage in acute injury of the hand? Because in acute injury, the hand will go into the position of comfort. In position of comfort, the metacarpophalangeal joint will go for extension or hyperextension, and IP joints will be going for flexion, and the thumb will be getting adducted. So if you keep that hand in that position, the ligaments will contract, and that will lead to stiff hand, and some cases it will go for contraction, especially in case of burns. And how will you splint the hand? All of us know that we should be immobilizing the joint above and below in case of fracture. What about the other time? It is always better to put the slab in position of safe immobilization. What is it? In position of safe immobilization, wrist is kept in 20 to 30 degree of extension, MCP joint in 70 to 90 degree of flexion, IP joints in neutral full extension, thumb is kept abducted, maintain first web space in mid circumflexion, and in thumb no metacarpophalangeal joint hyperextension. While keeping IP in extension, the collateral ligaments are stretched and tight, and volar plate is maximally stretched when compared to IP in flexion. In flexion, collateral ligaments are lax and loose. Fibers between the collateral ligament and palmar plates contract. When MCP joint is kept in flexion, collateral ligaments are stretched and tight. Greater bone surface area contact causing more joint stability. In MCP extension, collateral ligaments are lax and loose. Less bone surface contact causing less joint stability. So if you keep the collateral ligaments loose, that will go for tightening, and in later stage it will go for contraction. So that will lead to stiff hand. So we should never let the hand go into that position. What are the commonly used splint? The first and most commonly used splint is for flexor tendon injuries. We give dorsal blocking splint is used to hold wrist in mild flexion, MP joints in about 45 degree of flexion, and PAP and EAP joints in nearly full extension. In extensor tendon injury, the splintage is according to the zone of injury. In zone 1, 2, 3, that is finger injuries, finger extensor tendon injury. The finger splints are used like mallet splint or bottomless splint. In other zone, the splint is given in wrist in 30 to 40 degree of extension, MCP joint in 0 to 10 degree of flexion, and IP in full extension. And in case of fracture phalangeal metacarpal and soft tissue injuries along the ulnar border, it is usually dealt with ulnar gutter splint when it is undisplaced, and along the radial border, fractures and soft tissue injuries are dealt with the radial gutter splint. Thumb spica is used when we are dealing with fractures of the thumb or navicular fracture or lunate fracture and inflammatory condition like decurvins, tenosynovitis, along with soft tissue injuries. Cock-up splint is used usually in wrist drop and injuries around soft tissue as well as bony injuries around the wrist joint. And buddy stepping, all of us know that is commonly used for undisplaced fractures of phalanx along with dislocation of phalangeal joints. Coming to the physiotherapy part, physiotherapy is defined as the treatment of disease, injury, or deformity by physical methods such as massage, heat treatment, and exercise rather than by drug or surgery. Physical therapy's first documented account came from the old master of medicines by Hippocrates, who introduced the idea of manipulation for pain relief in the year 460 BC. Many different therapy programs and protocol exist, and these should be tailored to the individual case. The goals are very clear, and the core principle applied are control of pain, limiting soft tissue swelling, supporting the healing fracture or tendons, restoration of motion, restoration of function. The physiotherapy regime varies according to the injury type: tendon injuries, tendon transfers, fracture, nerve injuries of bones, or soft tissue injuries. Joint mobilization and manipulation technique, a common treatment used to address issues affecting the range of movement of joints. This technique is also utilized to treat pain associated with stiff joints. And deep transverse friction is a deep massage technique that helps to prevent or destroy adhesions and helps optimize the quality of the scar tissue. It also helps to evacuate the pain triggering metabolites. Myofascial release is a technique used to relax muscles that are affected by pain and stiffness. It stimulates the muscles to improve the circulation and increase flexibility within the muscle's connective tissue. It is commonly used for carpal tunnel syndrome and all. Manual traction is used mainly for lumbar or cervical disc problem. The gentle traction is applied. Acupuncture and dry needling uses needling along with other physiotherapy modalities. Tapping helps to avoid tension or excessive stress on the joints or muscles. And electrotherapy is the use of ultrasonogram, laser, and mild electric stimuli for the improvement of muscle function. Ionophores and phonophores are the methods by which drugs which are kept applied over the area is forced into the tissue by the use of mild electrical stimuli or by ultrasonogram. Now coming to the rehabilitation of tendon repair. The goal of tendon repair and rehabilitation is to achieve a normally gliding and functioning tendon. A strong tendon that glides freely is the motto. The concept of early mobilization is believed to be in favor of restoring gliding function, increasing tensile strength, improving tendon excursion, stimulating the restoration of the injured tendon. Mobilized tendons have a lot more benefits of immobilized tendon. They heal quicker, have fewer adhesions, overcome stiffness, overcome swelling of the digits, promote early return to function, reduce the likelihood of deformity formation. The rehabilitation protocol of flexor tendon repair, initially it was started immobilization protocol. Nowadays it is used for children and patients, they are not complying with mobilization protocol. Early passive mobilization and early active mobilization are the commonly used methods nowadays. Durance started the passive mobilization program in 1975, followed by Clean Arts in 1960. Then Clean Arts regime is active extension and passive flexion in 1967. Grattan and Belfast regime of early active motion is started in 1993. Early mobilization protocol are appropriate for alert motivated patients who understand the exercise program and precautions. Early passive mobilization, the basis it inhibits the restrictive adhesion formation, promotes synovial diffusion and thus healing, improves differential gliding of tendon, DNA synthesis at the repair site, improve tensile strength and increase vascularity. Basis of early active mobilization are nowadays the surgical techniques are improved and the materials and suture material we are using are less bulky. So we can start the mobilization at 24 to 48 hours post surgery, exercise frequently, increase the amount of tendon extension within the sheath, increase the in strength as well with the tendon extension. Combined MCP flexion and wrist extension protocol followed in early active mobilization put less tension on repair but more differential gliding. Coming to the rehabilitation post extensor tendon injury, traditionally we used to do static mobilization. Now flexor tendon protocols, early mobilization rehabilitation is used. Early active mobilization methods are used, and another regime is early controlled mobilization using a dynamic splint. Coming to the rehabilitation of injured nerves, the rehabilitation is mainly focused on preventing the muscle atrophy, maintaining range of motion of the joints, control of pain or of neural origin, sensory re-education, splinting for prevention of deformity. So these are done through splintage. Electrical stimulation is given to preventing muscle atrophy. Passive range of movement therapy is given for to joint mobility. Massaging, ultrasound and laser can be used for muscle well-being. The rehabilitation following finger fractures are designed to reduce swelling, minimize scarring, restore range of motion. Here also passive and active range of motion exercises are used. In case if the fixations are fixations are rigid, we can go for really active and passive mobilization protocol, thus preventing preventing edema, everything, and improve outcome. When the fracture is immobilized, undisplaced, we are keeping it in splintage. So in that cases, we had to go for mobilization protocol passive with the supervision. And while coming to the conclusion, a thorough knowledge of splintage and physiotherapy is very essential for any hand and plastic surgeon. Thank you for listening.